Test 1 2 3. Test 3 2 1.
It's okay. I'm okay. I got my shot. I'm good.
All right.
It's not going to affect you for 2 hours.
The Finance Committee will please come to order. We're already off the rails. I'd like to remind everyone to please speak into your microphone so that those watching online can hear us. Thank you all for being here this morning. Any citizens wishing to address the committee? They're seeing and hearing none. We'll move to item 3, which is approval of the minutes from the October 28th meeting. Entertain a motion to that end.
Move approval of the minutes.
Motion by Ms. Debose, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you all. Item 4, FY21 Year-End Investment Report. We have Mr. Greg Warner. Thank you, Greg, for being here again. We always enjoy your presentation. He's going to give us our investment report for FY21. Good morning and welcome.
Okay. Let's try that. There we go. First thing I'd like to do is just mention I've been asked to keep my comments fairly brief, so I'm going to go through this as quickly as I can, but I'm here to answer your questions. So if you need me to slow down or... Pardon? Well, there's a total of 18. However,
There is
none
a running joke about that, about the mean CEO that tries to limit all slide presentations to 6, but he's not very successful.
well, I could make it in 6 slides, but then the charts would be really small, and you'd complain about not being able to read
Oh,
it.
welcome to the JPS staff. You're following their guidelines. Okay,
promise-
Early, we'll put it in 6 slides, but we'll put so much on each one.
I promise to go through them quickly. The first thing I want to do is remind you, in reaction to the pandemic that began March of 2020 or so, the Federal Reserve cut the overnight Fed funds rate to 0. So we've been dealing now with essentially a 0 interest rate environment for about 20 months. And I'm going to see here if we've got our presentation up. I was told I could click through it. There it goes. All right, so let's start here. So we're going to start by taking a look at the portfolio. In summary, the portfolio at the end of September 30th, 2021 stood at about $1.07 billion. That's a pretty sizable increase from $949 million at the end of last year. That's a third straight year we've seen a very large increase. The majority of that is in the operating fund, which increased by about $118 million during the year. Now, just to be clear, that's not a function of the market value of the existing investments growing that dramatically. It's a function of additional funds coming into the hospital. The operating fund now makes up about 3/4 of the portfolio, and that's important because those funds traditionally must remain very liquid. That's your operating expenses that you need those funds on a short-term basis, and so that shortens our investment horizon, which of course limits our earnings potential there. Also keeps it closer to the 0% Fed funds target I mentioned a moment ago. It also makes the portfolio susceptible to changes in interest rates, and of course that's mostly been in the declining direction the last couple of years. You can see that at the bottom left of this chart, or excuse me, this bottom left table, where you can see the weighted average yield on the portfolio in total at the end of September was about 22 basis points, 0.22%. That's down pretty substantially from 0.64% a year ago and 2.34% 2 years ago. We do expect that interest rates are going to start trending higher as we move into next year, and so we're hopeful that we've seen the bottom in the portfolio yield and that it will begin to improve from here. On slide 3, we can take a look at some of the portfolio characteristics. The pie chart at the top right shows that we have 47% of the portfolio held in certificates of deposit. That's unchanged from last year, right about the same level that we were at last year. We've pursued certificates of deposit fairly aggressively because they've offered some nice yield advantages relative to other investment alternatives for the hospital. Unfortunately, they do require quite a bit of extra work on our part and the part of the hospital staff. But with the yield environment we're in, this is one area where we can dramatically improve earnings. And I'll show you some of those details in just a moment.
Why is
Yes, sir.
it hard on the part of the staff? You said that.
There's a little bit more work involved in it. When you're buying investment securities like treasury notes, that's mostly trading work that my firm does, that we take on. when you're doing certificates of deposit, it requires the direct intervention or the direct work on the part of the staff. So we're more of an introductory arm at that point, putting you in touch with the banks, but it's up to the staff to complete the paperwork, move the funds around, and those things. There's also more interest payments that have to be processed, and those interest payments are compounded into the CD, so there's a little bit of additional accounting work involved.
Great, thank you.
Sure. In terms of other investment allocations here, we cut the allocation to commercial paper a little bit this year. It was about 22% last year. We're down to 16% this year. The yield hasn't been as attractive, and frankly, we just haven't seen as much issuance. The balance of the portfolio is held in U.S. government treasuries and agencies, 9% in treasuries, 7% in agencies, about 2% in municipal bonds. We also have some bank deposits at about 8%. At the bottom left pie chart, you can see the allocation by issuer. You'll note here the largest allocations are with banks. Those are where your certificates of deposit are. We have 23% at East West Bank, 10% at Southside Bank, 9% at Veritex Bank, and 7% with Texas Independent Bank. The other large category here is Techstar, which is a local government investment pool, one of the primary liquidity options for the hospital at about 8%. Everything else is less than 5%, so 34% of the portfolio. All those other allocations are less than 5%, so we're very well diversified, which helps us to maintain the safety of the portfolio, which of course is the primary objective that we face. Maturity distribution in the middle there, we do have a high allocation in that 6 to 12 month bucket. That is sort of the area where bank CDs are the most attractive. We've also been positioning more there in preparation for what we expect to be higher interest rates next year. The obvious idea here is we want investments to mature so that they can be reinvested at higher levels, and we're anticipating that that will occur next year. The next page is what we call the benchmark comparison. This is looking at the yield on the hospital's portfolio versus some of the benchmarks that we follow. These are generally treasury benchmarks. The hospital's yield is the violet or purple line. It's the one running on the top on the right-hand side of the chart there. I mentioned to you last year that we expected the rate of decline or in the portfolio yield would slow and that we would be exceeding these benchmarks this year. That's exactly what we've seen as all those benchmarks have fallen, almost to zero. I was asked to elaborate on what exactly that means financially for the hospital. I could tell you that if we compare against a blended benchmark of the 6 and 12 month treasuries, we're outperforming that or beating that by about 18 basis points, 0.18%, and against an average portfolio balance of $1.1 million, that results in additional income of about $2 million per year. Compared against keeping all the funds in tax pool, which is sort of the default option for a lot of government agencies that don't actually invest their funds, you're beating tax pool by roughly 28 basis points over the last year. So that's an approximately $3 million in incremental income. And said another way, if you didn't implement the investment program that you have and kept all your money in tax pool, you would have earned last year about $550,000 instead of about $3.6 million. So it makes a significant impact, even in these low rate environments. And of course, as rates move higher, we do expect that those conditions should improve. That's basically all I wanted to cover on the investment report itself. I'd like to move in and take just a few minutes to update you on the economic and interest rate environment. I will go through this portion very quickly. I'm clearly not going to read all of these things. They're here for your review, but I can tell you I'll touch on a few of these subjects as I go through the presentation. This first one is a chart of new COVID cases in the United States. I'm sure you all in the medical field are all quite familiar with this, but certainly this has had a tremendous impact on the economy over the course of the last couple of years. What we are seeing is, even though cases now remain fairly elevated relative to when the pandemic began, our understanding of the virus, our understanding of its treatment and how to prevent it has certainly improved. And we do think that that this should not have as great an impact economically going forward. However, in the past, it did require a pretty dramatic response. This chart shows federal government spending, and in the years prior to the pandemic, you can see that generally government spending on a monthly basis was somewhere between 300 and 400 billion. That has ramped up and is generally running between 400 and 600 billion per month now. But you can see there were several months during the pandemic where we approached or even exceeded $1 trillion. And those are obviously the big government stimulus programs that you have heard about. And when we all got checks in the mailbox, it results in dramatically higher government spending. And of course, that helps to support the economy. This next chart is the Federal Reserve balance sheet, which you may have heard discussed of late. But you can think of this as the Federal Reserve's efforts to ease monetary policy and to stimulate economic activity. And of course, the change in their policy at the onset of the pandemic is very dramatic. And then they continue to increase their balance sheet, adding stimulus to the economy. They just last month announced that they're going to begin to taper their additions to their balance sheet. So they're not tightening monetary policy yet, but they're going to begin stimulating or slow the pace of stimulation to the economy in the months ahead. That has a dramatic impact in the economy. This is the M1 money supply. So this is basically cash and checking deposits. It's a very narrow measure of the money supply, but you can see it increase dramatically. I like to think of this essentially as money in people's bank accounts. That's largely what it is.
I wonder if my money supply could represent.
You'd like to see that. It's very dramatic when you see it
Put a little
collectively.
money in it first.
Employment indicators. So at the onset of the pandemic, you can see the red bar here, and I should have expanded this to capture March as well. But in March and April of 2020, the economy lost about 22.5 million jobs. We've since recovered about 18 million of those jobs, but that leaves us about 4 million jobs shy of the prior peak. You can see here in February of 2020, a little over 152 million people were employed in the United States. That today stands at about 148 million. So we're still about 4 million jobs shy of the prior peak. The unemployment rate, of course, shot up and then has declined. The blue line is the official unemployment rate, 4.6%. Obviously, it's been heading in the right direction, but we remain about 1% higher than we were prior to the pandemic. These are initial claims for unemployment benefits on the left and continuing claims for unemployment benefits on the right. The important thing here, of course, is these, after spiking very dramatically, have come way, way down. We're not quite back to pre-pandemic levels, but we're getting there. The chart on the right, the red line I want to highlight, the red line includes federal emergency pandemic benefits. These are the additional $300 and $600 weekly checks that you heard so much about. Those benefits expired on Labor Day, and so we're hopeful that folks are going to start coming back into the labor force now that all their employment benefits are going away. Speaking of the labor force, this is the labor force participation. The important thing to note here is that people just haven't come back to the workforce full bore yet. About 61.6% of the population is participating in the labor force, meaning they're either working or looking for work. That's about 1.7% below where it was before the pandemic. Consumer spending, the chart on the left, is retail spending. This primarily captures goods. About the only services captured is food and restaurants, as noted here. Again, you can see a big decline and then a sharp, sharp rebound. And one thing I will highlight on the chart on the left, this is monthly spending by consumers. It is not inflation adjusted. These are nominal dollars. So some of that increase is a result of consumers flat out paying higher prices. The chart on the right captures services spending. This line was a little bit slower to recover because services were shut down longer than goods. We've only recently begun to go back to movies and concerts and things like that. And so we've only recently seen services spending begin to recover. I've drawn trend lines on these charts. You can see that spending by consumers is running well ahead of those trend lines. And of course, consumers have been supported by higher wages and benefits from the government. This is the Purchasing Managers Survey, the ISM Manufacturing Index, and Non-Manufacturing Index. These are basically what purchasing managers are saying about conditions. Anything above 50 indicates growth or expansion. When you get into numbers in the 60s and approaching 65 on the Services Index, these are very strong rates of expansion in the economy. So basically, this is purchasing managers telling us that demand is outstripping supply. And of course, basic economics tells you what happens when demand exceeds supply, you get inflation. Inflation has become the big story and will be the big story for the next year. You can see prior to the pandemic, we were running just below 2% on virtually all the inflation indicators. We are now closer to 6% on the CPI, just above 6%. That's a 30-year high on CPI. You've no doubt heard the Federal Reserve officials and others talking about this being transitory, but it's beginning to broaden out and becoming more and more of an issue, and it's looking a little bit less transitory as time goes on. Inflation is going to be one of the big factors to consider for next year. Finally, economic growth. This is gross domestic product. This is essentially the scorecard for the economy. You can see after a big dip last year, we rebounded early part of this year, still had very strong growth through the summer months. In the last quarter ended September 30, growth did trend much lower. We've seen some of these stimulus and support go away. We did see a slight spike in coronavirus during the third quarter, and of course higher prices. And this data is adjusted for inflation, and so this is real growth, and so higher prices detract from growth, and so we see a little bit lower growth in this final quarter. And that takes us in then to the outlook, and essentially the outlook here is the economy is continuing to heal. We do expect continued improvement in the labor market. You've all no doubt seen stories of companies struggling to hire workers and find workers. That's leading to higher wages. We're seeing inflation in other areas. Inflation is going to be the big story for the next year, and the Fed's reaction to it will be a big story as well. And I'm going to skip the last two slides. These are just here for your benefit. You can compare yields in government securities today versus a year ago. Obviously, we've moved higher. And this final chart is just a table of security options that are available to us as public funds investors and gives you an indication where yields are.
26 slides, Greg.
There's only 18 on the economic stuff. 4 of them are on the investment report.
You are so fitting to be a staff member, the way you talk. It's just perfect. Yeah, that's the way it sounds.
This is always an interesting presentation. I appreciate it very much.
Thank you. I flew
Any
through it
questions
fairly
for
quickly.
Greg?
Happy to entertain any questions if you have any.
No, me too, because it's just something that I do not deal with.
Right, right.
And you've made it understandable.
Thank you.
Yeah, I wish I had economics professors like you. That would have helped a lot.
Would have made your 7 years a lot easier.
It would have definitely made it.
You would have gotten an associate's degree faster.
Daphne, can you do something about these people? Great. Thank you very much. Appreciate you being here.
Thank you.
Yeah, thank you.
All right. We'll move on to item 5, the CFO report. Sharon Clark. Good morning.
Good morning. So, it's crazy, the restrictions that our dollars are put under the Public Funds Investment Act. We are restricted into almost a riskless investment to protect the public funds. 40 basis points is not a lot, but it did provide us an additional $3 million on our bottom line this year. So Greg's a good partner. We do a lot of work around making sure that we are gathering every basis point that we possibly can. So it was a successful year compared to our benchmark. So thank you very much for that. Really, the other thing that I wanted to update you on is our external audit. BKD will be wrapping up their fieldwork next week. We do have a board meeting on December 16th, and that is when you will see the external audit. Chris Clark will be here to present. I think that's always an interesting presentation. He does some good comparisons with other public hospitals. I believe that BKD still has all 5 of the large public hospitals here in Texas. So Chris does have a whole lot of insight as to what's going on with the economics of supplemental payments. And so we look forward to finalizing that. It's a quick turnaround, but I think it's important to go ahead and get that year-end report final so we can go ahead and focus on the current fiscal year. All right. So October, just as a reminder, this is the first month of our new fiscal year for '22. We did not see very high admissions for the month, but if you look down at the case mix index, you can see that we were about 14%. It's staying on trend with where we've been in prior months. We kind of saw a dip back in May and June, but the case mix index does support our length of stay, which is about 14% over as well. So patients were sicker, they stayed a little bit longer. In our emergency department, we are about 8% under our budget, but we were pretty equal to the prior month of September. Urgent care is about 3% higher than anticipated through our budget process. Both our primary care and specialty care visits were under budget by about 5% and 9% respectively. And they both had about a 14% telehealth rate. So that rate has held steady for about the last quarter.
Thank you for the call out of the month today.
Yes, I apologize for that. Last month, we did not actually get to flip through our normal slide deck because I prepared kind of a special year end, but we do have 2 boxes for next month, Roger, that you requested. So we'll have.
Fisher box now.
Yes, so we removed the second box because we just have 1 month. The month and the year to date is actually the same in October. So. But yes, this is the month to date. So for observation cases, we were about right on target. And if you look at our surgeries, our inpatient surgeries were actually 5% over our budget, about the same they were in September. And our outpatient cases were about 30% under. We do still have some closures of the ORs that, a lot of the closures are having to do with staffing at the moment. So we will be looking at that in the coming months. So for behavioral health, you can see that our patient days there, they've actually remained very constant throughout the pandemic. But October, we were over budget by about 14% for the days there. Although our clinic visits were about 2% under, but that's pretty much on budget. Behavioral health, historically, at least for the last 12 or 18 months since we've actually been doing telehealth, there's a higher utilization for those virtual visits. They're at about 33% virtual for the month.
That's good.
Our emergency visits for our psychiatric emergency clinic were high this month, about 13% over, but it was a very similar experience to September. And then outside medical services, we were right about where we planned. These are the inpatients. Once they come to the emergency center, they are deemed to need an inpatient stay, and sometimes JPS is at capacity. So we do have partners, and I believe you're going to be hearing some of those contract renewals from Zillia later on renewal of some of those. But this represents the patient days that are done outside, but are at the expense of JPS for self-pay and our connection patients. So we're right on track for October. Yes, DT?
I'm not sure how to ask this question, but is there any correlation between behavioral health clinic visit and the emergency? I'm just trying to see if telehealth is effective or not. Because we have more telehealth, and then does that cause more emergency visit?
Yeah.
I don't know, so just.
I have not looked at that correlation, but
Yeah.
Yeah, 'cause
Start tracking
my
to see
question-
outcome.
My question is, what constitutes a behavioral health telehealth call? Is that them calling in an emergency? Is that us reaching out to them?
It's the experts.
So most of our telehealth visits are scheduled. So you may have a choice, instead of coming in for a scheduled consultation, you can actually do that on the phone. And the actual virtual visits, at least in my experience, have been through Epic. You
Okay.
actually log on to Epic. There may be a component of an unscheduled visit, but I'm not sure about that. Again, Zelia would be able
Okay.
to operationally speak
Thank you.
about that.
Note to Zelia, when you come in with answers.
I set her up really good for that, didn't I?
I was wondering if we can track maybe like a 48 or 72-hour rule.
Right.
If they do a telehealth, do they show up at the emergency clinic, then we can say, or can we divert more? Because we're supposed to have a lot more emergency, but because of telehealth, we help curve down that emergency visits. I can't tell one way or the other at this point.
So, yeah, our behavioral health emergency visits have risen over the last couple of years. As you can see, that's a 2-year trend plus the 1 month from this year. From the financial side, we have 314 days cash on hand that's available for operations. This would exclude the future fund. And you can see a nice change that happened in September is the striped part of the bar got really small. That was because we had highlighted the fact that we had not recognized the CARES Act money, and we had not recognized a large portion of the Medicare advance funding. So if you recall, in September, we did recognize $87 million, which was all of our CARES Act money. And we only have about 11 days of the Medicare advance funding, and that's being taken back through normal monthly claims. And so by the end of September, we expect to have that completely paid back as well. Yes, so over the next 12 months. Thank you. Our net accounts receivable stays very consistent. We're at 43 days this month. And then our FTEs per adjusted patient day at the bottom right is actually favorable. So last year we finished up at 5.84 FTEs per adjusted patient day. This year, this 1 month, we're at 5.8. And for the budget, we actually were at 6.1. Now, this is measuring hours worked. This is not measuring the cost of those hours. So you're going to see an unfavorable variance as we have tried to fill those positions. We are struggling with the staffing, as is every hospital in our area. So the cost of these FTEs, although this is favorable, the cost is going to be unfavorable on the next slide. So our connection enrollment, that turned out to be a really small slide. I apologize for that. It's increased, and we did add kind of a note at the bottom. We consistently talk about the churn of patients. The patients are eligible for 6 months, and we do have patients that are termed throughout the month, and we have new member enrollment. So we did add 2,600 this month with term members of just over 1,000.
Sharon, when you look at the connection enrollment, it averages around this between 40 and 43,000. Mm-hmm. Do we feel that there's a large number that we're missing, or this is basically where we're at?
You know, if you recall, we've had Michelle Haynes, who's our director over the eligibility area. A lot of our applications do come from people who are already accessing care here at JPS, and then we do a lot of outreach, trying to reach community members that may be in pockets. So, of course, some of that has slowed down because of COVID, and we're not able to get out like we used to. But it has held consistent for about the last 2 to 3 years. We have work to do in that area to make sure that the Connection program is visible, and we do have budget dollars for fiscal year 22 to make sure that we do some work around getting the right people the right care through Connection.
I asked that because I know Michelle came to one of the ministers' councils and made a presentation. And then she also came to my church and made a presentation. And I keep asking myself, is it that we're not understanding to be a part of JPS Connection, or they don't understand and are afraid to become a part of it? I don't know, but I just, when she came to the ministers group, it's a large group, but we didn't get much response back. So you're asking yourself, what is the key? And I was saying to myself, in the entire county, 43,000?
Right. It's not very many.
No, it's not, you know. It's,
Right.
And I think you're being optimistic, Sharon, because I think it's been more than 2 or 3 years. It's kind of been at a 40,
Yeah.
40-ish. It seemed like 5, 6 years.
Yeah,
It's sort of
yeah.
been in that zone. And we've seen the growth in the county. You would think it would be sort of
Wow,
something along those lines.
But yes, it has held very consistent. Again, the largest part of these members are entering our system either through the emergency department. We have eligibility out at the larger clinics, and we do try to reach out to those self-pay patients in Tarrant County.
Yeah, I thought that they had made some upgrades in how they did things. One of the things I think was shortening the application, what needed to be presented. I think that one of the things I heard was a lot of it can be done over the telephone. Now, am I imagining that, or?
No, we have tried to make the application process as easy as possible, especially over the last 5 years. You know, if we can find and validate information in any way, then we are trying to grant eligibility where we can. And especially throughout COVID, we have been able to, as you know, areas have shut down, although these eligibility centers have reopened. They have always had the ability to send stuff in via the mail, via email, doing online applications, et cetera. And people are available for phone consultations too.
What's the metric in terms of how many people apply and aren't eligible? Is that number going up, you know, or rejection rates going up, those kinds of things? That'd be interesting. We might have to have Michelle come visit us again.
We can update those presentations and bring back the experience. Now, remember, our eligibility department is much larger than just getting people enrolled in Connection. We actually try to find grants or Medicare and Medicaid. We go through all of those steps, and Connection by definition has always been kind of for anyone who is not eligible for other programs. So we do find a lot, you know, this is not the only people that we financially screen that are eligible. We do find a large amount of folks that can be qualified for Medicare or Medicaid through this process as well.
Do we have the ethnic makeup of Connection patients?
We do.
it would be good to see what that is.
Yeah, we will include
Just-
that in those.
And I'm saying it for being able to understand and interpret that. I will say this, though. I've seen Michelle in action a couple of times, and she goes above and beyond trying to get them. I mean, even for, I invited her to just do a personal one just to my staff at the church. I was looking trying to short circuit getting a medical plan. But anyway, but she did one-on-one consultation, you know, just to try to find out a way to get them certified. So I just wonder what is the drawback is?
Yeah, Michelle is definitely one of the biggest advocates here. And, you know, Reverend Emerson, as I meet the other eligibility people, some of the comments that we get, that's a very special group.
Yeah.
They really are advocates for our patients.
I think, Sharon, one of the areas that they have been talking to me in my community is we have our community center. Folks come in to apply for benefits for their lights and stuff. So eligibility is looking to see if they can have a person there, because that would be able to,
Yeah.
when they come in, that would be one-stop shopping. And so we are looking forward to the next part of that conversation to make sure that happens, because we think that at most of your community health centers, you have the CAP program there where folks are coming in applying. And so if eligibility, they're meeting those same guidelines, that if we could just be there as more exposure, that might improve our numbers. At least they would know about it.
I think it may make sense to look at the population churn so that we can see who's the base enrollment is, and then people falling in and out of that program. Then we can, because otherwise we may not see the number, but they're actually falling in and out. That's a lot of work to re-qualify them, and we may inadvertently highlight something that may pose a negative effect on our employee when they're working very, very hard, trying to get them re-enrollment and all that stuff up, so as well.
Why do they cycle out?
We have probably the last, again, 3 years, we've aggressively, as people have begun to approach their re-enrollment date. I mean, we use phone calls, we use mail, email if we have an email for them, trying to get them to re-enroll. But anecdotally, a lot of times if people don't perceive a need to re-enroll, they will just wait until there is a need, if they have an ER visit or if they have an inpatient stay. At that time, they will re-enroll. So our connection, if you do qualify for connection, much like Medicaid, there is a retroactivity that we allow for that. So if you do have an event and you're in our system, we're able to give you the benefit of that enrollment back a certain time period.
Yeah, that's the part that we need to understand so that we can categorize them.
Yeah.
Where are we from, do we have an active AEP program for Medicare Advantage or Medicaid, managed Medicaid? Does the enrollment is?
What program?
The enrollment for Medicare Advantage is between October 15 and December 7 or 8 or something like that?
So again, the eligibility area is certified as one of those recertification centers. So we are, and that was a big win a couple of years ago for that department. So we are able to advise people on what plan fits best for them. Is that your question?
Oh, no, I'm not talking about just for connection enrollment. I'm moving on to the other enrollment, right? Because we track between traditional Medicare and Medicare Advantage. I think we more into the reactive when they show up, then we know that they're part of that managed care program. But I think we should also start looking at the AEP to enroll healthier also as well, Medicare population into our program. That way we can, have that, secure that network of patients. And if we need some help with enrollment, I think we can negotiate with the Medicare Advantage for a certain fee so that they can help us with the enrollment so that we can hire the field marketing organization to go and enroll them so that it's more branding for JPS also as well.
Yes, so we do screen for Medicaid, and again, we are certified so that we can advise for any of the Medicare plans as well.
Right. Like, for instance, like let's pick one, like a merit group. I think we have a merit group. I think we can call them in and say, you know what, for us to expand this program, a global exchange, express or what exchange or whatever, we need to enroll more patients into your program. Give us some assistance, give us $500,000, give us $250,000. We put a team together and we go out and enroll patients into the program, educate them, say why they should enroll into this program rather than stay on the traditional one or switching to a better program based on their fit. I think we may be at that point where we should go out because we're talking about creating more revenue to pay for the hospital for later on, so we need more population coming into our organization.
Okay. But we will bring Michelle back, probably not in December because that's a really busy meeting, but we'll get her back at the beginning of next year.
I think we may want to take a look at differently because Medicaid eligibility for connection and Medicaid are very different than the Medicare side of it.
Yeah.
And the compliance issue and all that stuff. I think we may want to have start looking at a special group that understand that side of it to do recruitment.
Okay.
Thanks.
All right. It's a great conversation. Again, our payer mix doesn't change a whole lot month to month, so this only represents a month. For the income statement, we did have an unfavorable financial month for the medical center. Half of it was related to the underage that we see in net patient service revenue. And then we did have an overage in our salary dollars, as I alluded to in a prior slide. And we did have quite a bit of savings in some of the purchase services for some lower claims, as well as some delayed projects that we had budgeted for in October. That may be more of a timing difference as we get through the later months of this year. So for net patient service revenue, if you recall, our volumes were fairly low, and there was about a $2 million negative variance there for volume. We also had a high CMI, so that offset that negative volume variance by about $1 million. We also had an unfavorable mix this month, which was a negative, and probably about $2 million of this net patient service revenue is the CHIRP program. CMS has not yet approved the CHIRP program. If you recall, this was our DSRIP program ended last year, and HHSC had proposed this new program, and we actually would have gotten a premium payment on each and every claim process. So even though DSRIP was on a different line, the CHIRP program would be shown in net patient revenue. I know that there's been a lot of communication, both from the HHSC side here in Texas, as they are working with CMS nationally. So that program, number one, needs to be approved by CMS, and then if it is approved, CMS has the potential to go back retroactive and grant us those funds. So there will be more to come. I think there's going to be a lot of activity around this by the end of the calendar year. So on salaries, again, a lot of that overage is related to overtime as well as extra premium pay to cover shifts as needed. And then again, purchase service may be more of a timing issue, and we might see some catch up in the later months. But we did finish the year at 4.8 million. Again, that's about half of where we expected to be for this month's budget. For a claim, they had about they were right on target really for encounters. They were about 1% over, but and they also do telehealth through all the clinics that we saw on the medical center side. When you look at their volume, they're about 18% telehealth and virtual appointments. So for a claim, they finished the month ahead of their budget, about $2.2 million. They had favorable net patient service revenue this month. And again, part of that was due to higher encounters and a favorable payer mix on that side. Their salaries had a large savings. There are still some vacancies that we are trying to fill over on the Acclaim side. So when you combine the favorable revenue and the favorable expenses, that's where that $1 million is coming from. And if you look at the combined for the health system overall, we ended the month at about 2.7 million favorable compared to a $6.7 million budget. Again, a large part of that is the suspended CHIRP payment that will have more information to come in the next few months. Are there any questions for the month of October? Okay. Thank you.
We need to consider acceptance of the October financials.
October.
We have a motion by Reverend Emerson, second by Ms. Debose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Sharon, very much. Rory McCready.
Yes, sir.
Item B, please. B, C, and D. And E. It's the Roy McCready Show.
Thank you, Mr. Chairman. They continue to put me in the leadoff spot here.
We like it.
The message was soften them up, so see what I can do.
Good luck.
Yeah.
Let's
This group doesn't soften up much.
No. Let's take B, C, and D kind of in tandem for discussion, but let you guys obviously do a separate motion on those.
Right.
These are 3 different home health contracts for Connections members that we would need to provide home health care for them. We have, in the last couple of years, we have developed a quality system for rating these home health companies. We have 4 quality metrics that we're looking at, and those companies, the data actually comes from CMS and the star rating system. And then we take that data and we developed a model to score them, and then they are able to earn a slightly higher payment for better quality and a little lower payment when their quality is not as it should be. So those 3 contracts there, we can take motions on those.
They're all essentially uniform contracts.
Yes, very, very standard terms, standard payment rates, and the quality measures are across all of the home health agencies.
Any questions for Rory on these items?
I have one question on, they are all for different price, so that is, they had different, more patients than, how did you set what we were putting in this contract? What was it based on?
Sure, good question. It really is based on historical run rate on what we've spent. with them. We obviously have to kind of have a broad pool there for home health because we need multiple companies. One can't take care of all the patients.
Okay,
So.
all right, thanks.
On the, go ahead, I'm sorry.
Sorry, I have a question on, so these are the home health that a claim doctor referred to, is that right?
Well, so when our patients would be leaving, and they wouldn't go to skilled nursing or rehab, they would go to a home health care type setting, typically would be discharged from a hospital type setting to go there, to their home.
To the home, okay. Does that physician have signed the conflict of interest?
All of our physicians, and this would be.
Let me simplify it, because I've seen a lot of abuse or borderline, because it's not kickback, but sometimes they refer to certain home health or DME, and they recertify them. But at the same time, they take a medical director or consulting fee, so they're not really treated as kickback, but they actually have a consulting arrangement with home health or DME. I just want to make sure that we have that covered so that we don't have to deal with that later on with kickback. Because it.
Yeah, absolutely. You're kind of, you're delving into more the compliance world.
Because it's not a compliance issue, but it will pass compliance, but it will not pass the smell test.
So I would say from a compliance issue, the physicians will have to fill out conflict of interest if these relationships exist. So there would be an awareness on the compliance side. And then on top of it, we're blind to the home health agency that's facilitated through case management. We tend to be blind to that as we order the DME or order home health services.
Okay. Yes, sir.
Quick answer to your question, DT. To my knowledge, we do not have formal medical director agreements in place with our physicians who are in particular focused on the type of care for these patients with these entities. We do review that per Dr. Schrader's comment on an annual basis related to conflict of interest. And while I'm getting more comfortable with understanding that, I think for the purposes of what Rory's describing, we would be free of that potential both bias and concern organizationally.
Oh, I see. Okay. I just want to make sure that we look further ahead.
Thank you, Dr. Becker.
Thank you.
Okay. Any other questions for Rory on? And I just want to note to whomever wants to make the motion is that all three of these are exemption to bids as well.
Defer to Dorothy to do that. It's qualified to make that
There's
motion.
only,
I'm going to give this duty up in a few months, okay?
one for old time's sake, huh?
All right, for the first one, move to approve the exception to bid and the home care agreement between Healthcare Masters Home Care.
Okay, you've heard them. I have a motion. Do I have a second? Second by Reverend Emerson. On favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you. Item C, Madam Chairman.
Move to approve the exemption to bid for home care service agreement between Amazing Grace Home Health Care Agency.
We have a motion by Ms. Debose, second by Dr. Schrader. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Item D, Madam Chairman.
Okay. Move to approve the exemption to bid and home care service agreement between Rosa's First Quality Healthcare, Home Healthcare. Okay. All right.
A motion by Ms. Debose, second by Mr. Wynn. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you. Thank you, Rory, for that. Thank you, Madam Chair. Item E, Rory.
Thank you. Next up, item E is a contract with a company by the name of RevSpring. RevSpring was selected from RFP of 5 responses for our patient statement process. We do have to have patient collection processes for sending statements and managing that process. We selected RevSpring primarily because they They were one of the most cost-effective, but they also brought some additional functionality. We are beginning to launch things like text-to-pay, so a patient would get a text message and then be able to essentially respond to that message and pay their bill. So some things that you would typically see with your cell phone bill or things like that we're bringing to the table. Also, this company is bringing us a 24-hour automated phone payment system, which we have not had in the past, and then other things like paperless statements. So I feel like we've selected a good partner for this process.
Great. Any
Would I be
questions?
able to give you the report for 3 statements so that you can file for your cost report and everything else behind it?
Sure. As far as your requirements for cost reporting, we track most of that within Epic as far as the dates required for statements and being in compliance with that for cost reporting purposes.
Oh, I see. Okay. Is this for day 0, or is it after 30 days before they send the statement out?
It depends on it of course depends on whether they're insured or not. An uninsured patient will probably get a bill probably closer to day 5 or day 6 after their service. Then, of course, an insurance patient would get a bill day 5 or 6 after their insurance actually pays their portion.
Oh, I see. Okay, thank you.
Okay. Any other questions for Rory on item E? Entertain a motion. Motion by Mr. Wynn, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you. One more, Rory.
Okay, item F is a revenue generator, so we'll switch gears here for a minute.
Mr. Fisher's in.
Bright Healthcare is a new marketplace plan entrant into the Fort Worth market. And marketplace plans, if you follow some of the recent legislation with the Build Back Better bill, marketplace plans are going to get more and more important in the overall structure of how we try to move people from uninsured to insured. So Bright actually has been a good partner with us. They're creating more of what I would call a narrow network. We are not the only hospital, but we are one of 2 in the Fort Worth market. So they're not taking a broad kind of shotgun approach to enrolling hospitals. They're keeping it narrower, and we're going to work with them. Hopefully in 2023, we'll also have a Medicare Advantage product with them in the Fort Worth market. So
Is this one of those, the non-ACA compliant plans? They're kind of skinnier plans?
this is actually an ACA plan.
Awesome.
And of course, we've done the hospital agreement before you today, and we're also very close to finishing up the Acclaim agreement. So those 2 will really launch in January. So there'll be another option for our patients to pick an ACA plan.
Great.
Have they addressed my concern about this one is that according to the National Association for Insurance Commissioner, their rate of complaint is 7 times higher than the national average. So have you guys looked into that and feel comfortable with
I'm sorry, 7 times?
complaint?
Complaints.
Yeah, so that was according to the National Association of what?
Of insurance commissioners, the NAIC.
And what are they recommended?
They're 7 times higher than the national average in terms of the rate of complaint.
Rate of complaint?
Yes, sir.
Yeah, define that.
Variety of reason.
I can follow up with them. DT, they've had a good leadership team.
Right, denial payments. And
They've had a good leadership team working with us. I can follow up and see what their response is on that and get back to you on it.
Okay. Because that's the only concern I have, is that we don't want to attach ourselves to somebody who got a lot of complaint. But if that's a legitimate reason why, I'm good with it, but.
Sure.
Yeah, if it's a high rate, it would be good to find out in what area that is.
what's the prerogative of the committee? you want to hold this? You want to move it?
I would point out, we have a 30-day out clause on this, just so, if that helps inform your decision.
Okay. What's the pleasure of the committee?
I have no problems approving, recommend approval, and then when Roy comes back with that, we can then make an additional decision.
We have a 30-day out if there's an issue down the road.
So moved.
Okay, we have a motion by Reverend Emerson. Do I hear a second?
Second.
Second by Ms. Debose. All in favor of the motion, please say aye.
Aye.
Opposed? Mr. Nguyen, noted by parliamentarian. Thank you, Roy, very much. Appreciate you. Doug Chung, item G. Good morning.
Good morning. All right, thank you for having me here today. This is a letter of commitment between Takeda and the hospital district. And essentially what this is just that we are committing an annual purchase about 4,150 units per quarter. We currently purchase about 5,000 units per quarter. By doing this over the next 2 years, we set to save about $54,000 over that time period. This is already kind of a MedExec approved workflow where it's an auto substitution that's already been kind of worked through that entire clinical process there. So it is on Vizient GPO. So any questions?
Any questions for Doug? Okay. Entertain a motion on item G. Motion by Reverend Emerson. Do I hear a second? Second by Ms. Debose. All in favor of the motion, please say aye.
Aye.
I didn't say a word. That was DT seconded.
I just heard a mumbling from that general direction. Let me clarify the second. We have a motion by Reverend Emerson, a second by Mr. Nguyen. All in favor of the motion, please say aye.
Aye.
Those
Opposed?
two are misbehaving.
They are. We have to separate them. All opposed? Motion passes. Thank you, Doug.
Thank you.
Bama Ball, we've got some questions for you.
I heard.
Before you dive into your items, we have a question about, what do we have a question about? Telehealth.
It was about, is this on?
I don't know, Mr. Nguyen had some,
Okay, about telehealth and whether the telehealth in the outpatient is reducing PEC numbers. That's what it was. So with our telehealth, we offer telehealth for existing patients in our outpatient clinics. And the patients love doing the telehealth. And for behavioral health in particular, it works extremely well. But we also, at our Terrell location, we have same-day and emergent telehealth availability. So if a patient walks into the clinic, and or not even necessarily a patient, but somebody just literally walks into the clinic, which happens daily, we will connect them immediately via telehealth with a provider to have an immediate intervention. And that way we're able to prevent them from having to go to the PEC. And we also are offering telehealth for intakes, because pre-COVID, the intakes were all in person. And we had about a 35% no-show rate with intakes. And when we moved it to telephone or telehealth, because whatever we can get our patients, whether it's telephone or telehealth, for an intake, our no-show rates dropped to like 12%. And so whenever post-COVID is, which remains to be seen, we're still going to keep telehealth as part of our offerings for outreach for our patients, as well as the intake process, because it allows us to meet our patients where they are, and it's improving the access, because those individuals who are doing intakes by phone or telehealth are actually having a much lower no-show rate to their first appointment as well. And so this has really increased access. What I think is happening, and I've been saying this for quite some time with regards to the tremendous volume in the PEC, is many of you may have heard on TV or read, we're in what's called the fourth pandemic, which is the mental health pandemic. And it is a culmination of many of the challenges and grief and hardship and everything from the ongoing COVID pandemic, and people can't cope. They've lost their ability to cope, but it's also indicative of the lack of available resources for behavioral health across America. And certainly Fort Worth is not any different, except JPS offers a great deal of behavioral health to Tarrant County residents. However, right now, the volumes in the PEC, I truly believe, and it's been like this since about fall of 2020 and winter of 2020. Our volumes have been like that in the PEC because a lot of community organizations that would normally help people with behavioral health shut down when COVID hit. And then they've come back up, but they're not fully opened, or they're only doing telehealth, and sometimes it's challenging when that's your only option, whereas we have a hybrid option. If a patient says, I can only do telehealth, great. If a patient says, I can only do a phone, great. If they say, I want to come in, great. We're not going to put any barrier up for a patient accessing our services. And that's been the same across our district with any service. But in the community with some other community providers, I can't say the same. And so the resources that were once available as part of a behavioral health safety net at the community level declined dramatically when COVID hit. And that has impacted people being able to sometimes get their regular psychotropic long-term injections, you name it. And so that has been a challenge.
I have several questions for you about
Okay.
the area for telehealth. For telehealth, are they sophisticated enough, like the call center where you can track wait time, drop off, and all that stuff? Because where you have more access, but people can't. Do we have the bandwidth for that and all that stuff? Do we track those?
We actually do track that. I don't have that with me, but I can get that for you, DT, because our call center tracks wait time and everything for telehealth.
And how does it work for a patient that doesn't speak English? Do we have translation within the telehealth?
We do. We have translators. Mm-hmm.
And another question for you is that does telehealth, when they walk into the PEC, they cover under EMTALA law?
I'm sorry, I couldn't hear
They
you.
cover under EMTALA, but when they call in for emergency or something like that, do we follow the same guideline?
No.
Okay.
So if somebody is calling from their home, they're not bound to EMTALA. EMTALA is when someone is physically located on the campus in an emergency room.
Right, but what happened
If we're not
they don't have
comfortable,
insurance and then they got caught up with filling out paperwork before they can talk to a professional?
we have them talk to the professional first.
First, okay.
Yes.
What
And I will tell you, DT, that we've been doing this, but certainly moving to telehealth or telephone, if our counselors and providers do not feel comfortable after a telehealth visit or a telephone visit, they will call the police in that area to do a welfare check on that patient.
Okay. So what happened if we're doing a great job and people know about us and they just pass our card and then now we are the crisis center for the whole nation without getting paid?
I'm not sure what you mean with that getting paid.
Well, when they call for telehealth, and if they're from different counties, that we don't have any, they
So
don't have
if
any
they're
way
from
of paying for it. And
if-
now we become a national center for crisis without getting paid.
So if they're calling for a we don't see anybody outpatient outside of Tarrant County that's indigent.
Okay.
So we're not allowed to. So if somebody has insurance and they're outside of Tarrant County and they've already been connected to our inpatient services, we may see that individual, but as far as being indigent, we're not able to do that because they're not Tarrant County residents.
All right, thank you.
You're welcome.
That verification's based on what they tell you at check-in?
Typically, their previous patients, inpatient, we get a lot of patients from Parker and Johnson County that are brought in by their police to the psych emergency center. And so typically, they've already established with us for inpatient, and then they're back home and they want to come to our outpatient, and we're not able to do so.
You said we're not able to do that, correct?
Yes.
Well, we don't know enough to ask more.
I know you can. I'm waiting.
Y'all are here always. Let's move to item 8 for now. And Zelia, go ahead.
Okay. I'm asking for you all to consider approval. It's a two-part exemption to bid, and number 2, for outside psychiatric medical services agreement between Perimeter Behavioral Hospital of Arlington and the Tarrant County Hospital District. This is for $2 million annually, but that's based on a previous spend when we had Sundance before. But this hospital is child and adolescent only. And that is one of the areas that we're seeing a major increase in coming to our psych emergency center, are children and adolescents. So this affords us another opportunity to have a safe bed for these kids to go to.
Okay, any questions for Zelia on this item? Motion by Mr. Fisher. Second by Reverend Emerson. All in favor, please say aye. Opposed? Motion passes. Thank you, Zelia. Item I.
Thank you. Again, this is two-part. One is an exemption to bid, and then the second is for psych outside medical services agreement between Mesa Springs and Tarrant County Hospital District. This is for $230,000 annually, which is approved in the FY22 operation budget. That's based on previous year spend. They have an adolescent unit here at Mesa Springs as well as an adult unit, and so this affords us an opportunity to have more bed availability options when our capacity is full here at JPS, which is daily.
Yeah. Right. Any questions for Zelia on this item?
I move to approve the exemption to bid in the contract for the psychiatric outside service medical agreement between Mesa Springs.
Hear the motion from Ms. Debose, and hear a second. Second by Dr. Schrader. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item J.
Okay, again, a two-part. One is an exemption to bid, and the second is for outside medical service agreement between JPS and THR, Texas Health Resources. This is for all of their hospitals that have behavioral health. They have adolescent as well as adult behavioral health, and they have been helpful with us in the past when we have been at capacity for both adults and adolescents. And it's $245,000 annually based on previous year's spend.
All right, move approval of the exemption to, the exception to bid and the approval of the agreement between JPS and Texas Health Resources.
Okay, heard the motion, or you've heard a motion. Do I hear a second?
Second.
Second by Reverend Emerson. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes.
Dorothy, you can never leave the board. You have an itch. Exactly, it's security.
All right, so item K.
Okay.
K and L are similar, correct?
Yes, they are. They're actually different school districts, but both grant-funded.
Okay.
First one is consider approval of an interlocal agreement for the provision of pediatric and adolescent behavioral health services between the Hearst, Euless, Bedford Independent School District and Tarrant County Hospital District. And this is no cost to JPS. This is funded through the grant through Senate Bill 11 with the Texas Child Mental Health Consortium. And would ask for your approval. Do you want me to do the second one too?
Those two are essentially the same, right?
They are.
Yeah, go ahead and lay them out, and we'll do them. We'll vote on them one at a time.
Okay, and then the second one is another interlocal agreement for the provision of pediatric and adolescent services between Birdville ISD and Tarrant County Hospital District. Again, there is no cost associated to JPS. It's funded through the grant through Senate Bill 11.
Awesome. Okay.
Move approval.
Item K?
Yes.
Yes, sir. We have a motion on item K. Do I have a second by Ms. Debose? All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Item L, do I hear a motion? By Reverend Emerson. Second by Ms. Debose. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Zelia.
Thank you.
We'll probably have some more questions for you. We're saving them up for you.
Okay.
Thank you very much.
Thank y'all.
Psychiatric services is one of those little-known real jewels that we provide.
Enormously
Does
important.
not get enough publicity
Agreed.
in the county.
Agreed.
And just note to that lady and the people that work around her and the incredible team at Behavioral Health, when Joint Commission came, no sightings on so many different areas. That is amazing to get that kind of report. So to the Cheryl Herds of the world, the Zelia Balls of the world, Shannon, Amy, everybody over there, that is an incredible team. That doesn't happen. That puts you in a 0.1%. And you and I both talked about that about 6 months ago. And it's like, how are we going to do this? And not only did they went through with flying colors. When you're cited more for best practices than you are citations, this board and this group needs to take a breather and go, we really are spectacular. That's amazing.
Thank you, Zelia.
Zelia, good job to you and your team. And I know that's it's out of order, Mr. Chair, but a lot of the things that you say are as well. But I wanted to let you know how incredibly great that is.
Thank you, Zelia.
We've not heard about.
I would like to say that my team is incredible, and we would not be successful without them. And we wouldn't be successful without your support as a board for giving us the resources to be able to do our job. So thank you.
Thank you, Zelia.
A private consult.
There we go.
I'll take a telehealth.
Mr. Mendenhall, item M.
Good morning, everyone. This contract is coming to you today from Epic, and we did an RFP for this particular contract. And there were 3 responders to it, BMD and RX Works, that responded to this. And at the end of the day, we chose Epic because of the integration that we can get, and we don't have to write as many interfaces going in and out of Epic. So this is a 5-year contract, has a 90-day out clause, like every Epic contract that we do with it, to be able to look at all of our using Epic Willow to look at our pharmacy inventory and be able to manage it better at the jail, the outpatient clinics, and so on and so forth.
Awesome. Any questions for David?
Is that
Motion by Mr. Debose, second by Reverend Emerson. All in favor of the motion, please say aye.
aye?
Opposed? Motion passes. Thank you, David. Mr. Lane, item N-O. N-O.
Good morning, everyone.
Sorry, Freudian slip.
It just flows from you, doesn't it?
It does. It does. Thank you. Thanks.
Okay, I'm done.
Thanks for playing. Item N.
So I'm here to present the agreement between Beck Architecture LLC and Tarrant County for $4.034 million. This is for architectural and engineering design services only for the new psychiatric emergency center. As you may recall, Beck was approved by the Planning Committee on the 28th, the previous meeting. Again, this aligns with the master plan that was approved. Broadus has asked us to move this agreement forward, and they have a 26.22 hub participation rate.
Okay. This is the first of many to come.
Yes, sir.
Any questions for Adam on this?
This is the temporary but permanent facility?
Yes. But not permanent PEC.
Yes.
Technically. We have a motion by Mr. Fisher, second by Ms. Debose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Adam. Go to O, please.
So to show that I don't always ask for money, I'm bringing money. This is an agreement between Lori's Gifts and Tarrant County Hospital District for $38.5 annual revenue for a one-year lease. They currently operate the gift shop downstairs. This is for one-year continuance. Also, there's a percentage lease payment that comes from their sales. We have right to terminate as over 30 days at any time.
Okay. Any questions for Adam on this one?
Move approval.
Motion by Ms. Debose, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion
Have a good
passes.
day.
Thank you, Adam. Dina, item P.
Good afternoon.
It's still morning.
Good morning.
Morning? Morning?
Good morning. I'm still sober. It's morning.
She was up way before us.
This is a very tough crowd today.
It is, I'm telling you. A little feisty.
Requesting consideration of approval for a purchase agreement between Stryker Sales and Tarrant County Hospital District. This is a one-time purchase that is approved in FY '22 capital, $638,502. This Stryker agreement provides for surgical drills, saws, and reamers for ortho and podiatry patients.
Okay. Any questions for Dina? Motion by Reverend Emerson, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. All right, Dina, thank you. Item Q.
Consider approval of master design options purchase agreement. It's between B. Braun and Tarrant County Hospital, $186,624, which is included in FY '22 operational budget. Does have a possible 5-year term with a cost of $933,120. B. Braun provides spinal and epidural anesthesia trays for patient care.
Questions for Dina? Motion by Dr. Schrader, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank you.
Dina. Item R.
All right, third one for me. Consider approval of a purchase agreement between Olympus and Tarrant County Hospital District. This purchase is included in our FY '22 capital budget. $676,031 is a one-time purchase. It provides ultrasound technology for our endoscopy unit for patient care.
Okay. Move approval.
Motion by Mr. Debose, second by Mr. Nguyen. Any questions for Dina before we vote? All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Dina, very
Thank you.
much. Item 7 is planning committee items, which there are none for discussion for today. Counselor, are there any closed door items? Okay. Without further business, we're adjourned.
All right. No closed session today. We have no citizens wishing to address the committee. The next on our agenda is approval of the minutes. Are there any corrections to the minutes? There being no corrections, I'll entertain. Okay. Moved by Roger, second by Steve. All those in favor of approving the minutes signify by saying aye. Aye. All those opposed by nay. Okay. Karen, Dr. Duncan, did you have an update that you wanted to?
Yes, thank you. Very brief update. I did want to update the board on several items. The first one is the Senior Vice President for HR search. As Robert mentioned to the board previously, we had interviewed a couple of candidates and then asked Heart Search, who is doing our search for us, to go back out and expand that search. The expanded list of candidates will be presented to us following the Thanksgiving holiday, and we hope soon after that we will be setting up interviews and being able to identify the next Senior Vice President of HR. We understand the criticality and the importance of having this position. The second update is regarding the equity and market review that the board approved for the FY22 budget year. I did want to let the team to know that the HR team is working day and night along with Mercer to complete that equity and market review. We are on schedule to have the equity review and adjustments completed by the end of this year. And Mercer has already given us preliminary data regarding the market review. That review will be completed by the end of this year and paid out at the beginning of the next first part of next year. So we're well on the way to completing that. And then just to let the board know that there will be a special call meeting of this HR committee on December 9th of this year, and that allows me to share the results of the FY21 annual incentive program and the long-term incentive program results with you, and to bring forward some recommendations as to how we will settle and pay that out. It also will allow me to bring forward the work that the team has done in establishing the FY22 fiscal year 22 goals moving forward. And Madam Chairwoman, I believe, those are all the updates that I have. Any questions at all?
All right. Okay.
Thank you.
Thank you. Okay. Now, I'm ready to go and close, right?
Yes.
Okay. For item 5, we will need to close the public meeting and go into closed session, and that will be for board members only and with legal counsel. Okay? Thank you. All right, I will call us into open session again at 1:58, and we have 3 items for approval. And the first one would be approval of the resolution authorizing the amendment of the JPS pension plan and GEBA. All right, it's moved by Roger, second by Steve. Are there any other discussions? All those in favor signify by saying aye. And those opposed by nay. Okay. The second is the approval of appointing Dr. Karen Duncan as the Tarrant County Hospital District Administrator to serve as the President and CEO of JPS effective January 1st, 2022.
So moved.
All right, moved by Ralph, second by Steve Montgomery. All those in favor signify by saying aye. Aye. Those opposed by nay. Motion carries. Thirdly, we have approval of a request from General Counsel to move forward with action necessary in connection with the opioid litigation that we discussed. All right, moved by Steve Montgomery, second by Ralph. All those in favor signify by saying aye. Aye. And those opposed by nay. Okay, motion carries. That concludes our business, and I would just like to thank the board and all of you for your participation and welcome Robert. Thank you for all you've done for us, okay?
Yes, ma'am.
Now, you want me to make it a little bit more so you can cry a little bit?
No, ma'am.
All right, then. There being no further business, we are adjourned, okay? Thank you.